I will welcome you all to our October session of Zoom Seekers. It's my sister's birthday today, so if anyone wants to send her a note later on, I know she'll appreciate that. So happy birthday, Susie. But we are not here tonight to discuss my sister's birthday, but instead we're going to talk about a little bit about COVID stuff, because it was interesting. There was a story in the paper today in LA County. One of the ways they're measuring, I don't know if it's how widespread, but what rates of infection stuff are by detecting COVID in wastewater, which I thought was actually, that's pretty clever, because especially nowadays, I'm guessing a lot of people don't necessarily report it because a lot of it's mild. And they were saying that the numbers have dropped significantly in the last week or so. So we've been on a little bit of an upsurge, and maybe we're peaking down a little bit, but maybe we should talk to someone who actually knows what she's talking about, instead of just doing, well, when she says I'm doing my own research, it's legitimate research and everything else. So Charlotte Sadler is down at UC San Diego, and I actually met her the first time when I got COVID, that she was dealing with a sort of a divers who have COVID type study. I'm not sure that's not the right word, but that's how I hooked up with her. And then I've been sort of bugging her ever since and convinced her to come on and share some of what she knows with us in this format. So without further ado, please welcome to Zoom Seekers, Dr. Charlotte Sadler, and give her the appropriate Zoom Seekers welcome. So Charlotte, all you.
Hi, thank you so much for having me. It's a pleasure to be here, and I appreciate, especially those of you who are on the East Coast and staying up late. That is way past my bedtime, so I appreciate it. I'm just going to open up my slides here, so just give me 1 second. All right, let me put this into a slideshow, and then we should be good.
I'm done.
Yeah.
That's okay.
All right, there we go. So like I said, thank you so much for having me here. This is a real pleasure to be here. There's always a part of me that is a little bit bummed that we're still talking about COVID, but I think it is here to stay. And I think that there are some real issues that pertain specifically to divers. So I'm very grateful that you had me here tonight. This is just my quick disclosure. Obviously, this is an informational talk only. It should not be interpreted as specific medical advice. So I do want to make some acknowledgments. I think probably one of the reasons that I got asked to be here tonight is I don't pretend to know more about COVID than many of the other wonderful colleagues that I work with, but I have done a lot of work trying to organize some of our guidelines around COVID. It's actually where I've spent a lot of my efforts in research in the last 3 years. So I have been kind of really deep into COVID, and I was the lead author on some guidelines that we published at UCSD. And these guidelines really were the first guidelines that were published specifically related to divers and how COVID-19 was affecting divers. So I think that's probably the reason that I got asked to be here tonight. So I'm very grateful, but I'm very grateful for all of my colleagues who helped me put those together and for the funding that I received. We were supported by UCSD and also the Patty Foundation, which has been incredibly generous to us. So the goals and objectives, I'm going to do a brief introduction. We're going to do a little bit of time traveling, actually, and go back to 2020, which was probably a little bit traumatic for all of us, but we're going to get through it. I want to walk all of you through how we developed our initial guidelines, because I think for most people, there really isn't a lot of background on exactly how that process went. And it was new for us as well. And then kind of give you some updates and some revisions in the guidelines that we've done over the past few years. And then finally, we're going to end with touching base on what I foresee to be future challenges. And then at the end, of course, we'll just open this up to Q&A. And I'm hoping to have a good discussion if anyone has anything that they want to talk about. So just to introduce myself a little bit more. So my training, I did my residency in emergency medicine at UCSD. And then I stayed there for fellowship in undersea and hyperbaric medicine. And so currently I'm still there. I never left. You can see on the right here, that's a picture of our beautiful chamber in Encinitas. That's a picture of our emergency department. And that's where I currently spend most of my time. So I spend probably about 40% of my clinical time in the emergency department and 30% of my time in the hyperbaric chamber. And then I do the rest of it. I have a bunch of admin stuff that I do. So I'm the program director actually for our fellowship. And probably the most relevant thing tonight that I do is I actually work at our occupational medicine dive clinic. So UCSD is pretty unique. we have a dive clinic that we run once weekly on Wednesday mornings. That's run by myself and 3 other professors there. And what we do is it's a dive clinic that is only for divers. We see recreational, scientific, and commercial divers. So for our scientific and commercial divers, most of what we are doing is doing their yearly physicals, yearly exams. That sometimes includes imaging, spirometry, and this kind of making sure, touching base and making sure that everything is going well. And then if they have any sort of acute injuries, if they have a diving incident, they need to come back, they come and see us again to kind of return to dive. The recreational side of things is quite interesting. We kind of see the whole spread. So we have people who maybe have had prior health issues who want to get into diving and want to know if that's possible for them. We have people who have been longtime divers and may have a diving accident that want to come get reevaluated, or they'll have some sort of a medical event that happens, especially as our divers are aging, and they want to know if they can continue to dive. So we see, like I said, a big spectrum of divers at our dive clinic. And a lot of what we have seen over the past 3 years has been divers who have had COVID and wanting to get back to diving. So this is the time traveling that I'm talking about. I hope no one gets too traumatized. But I want to bring you back to March 2020, because I think sometimes it's important to just take a beat and remember how little we knew at that point. So I remember I was working in the emergency department during this period of my life. And it was crazy, to be honest. Like, we had no idea what was coming. At that point, we didn't even know like what protective equipment to wear. Should we be wearing masks? Should we be wearing N95s? We didn't really know what was happening. What we saw, of course, was just kind of catastrophic events happening all around the world, especially it seemed to hit the East Coast before it hit us. So on the one hand, we were kind of looking at a economic and world shutdown. We were looking at a pandemic and a health crisis. And then on a very microscopic level, we were actually very worried about our divers. And I don't know if any of you saw this blog post that I have up here from What Notes. So this was a really interesting blog post that got a ton of attention in the diving community. So this was published in April of 2020. It was written by a German physician. And he was a pulmonologist in Germany, and he was seeing a lot of very young people get very serious cases of COVID. And he was a diver himself, and a lot of his patients were divers. And he published this blog article, and he published some imaging. So the picture there, that's a chest CT from one of his patients that he put on the blog post. And he essentially said, I am seeing all these young people with COVID. They're all divers, and no one is ever going to be able to dive again if they've had COVID. And this really shook up a lot of people. So it shook up a lot of people in the diving world. And, we realized that, yes, we're a fairly small population when you consider the global population, but still a significant portion of people. For us, we were talking about, these are people who this is their livelihood. They're commercial divers or scientific divers. And at this point, we realized that it was inevitable that COVID was coming to our community. And we got really nervous about how and if these people were going to be able to go back to diving after having COVID. So, like I said, back when this was going on, from a medical standpoint, and when we were thinking about diving, we started thinking, okay, based on what we are seeing with COVID, which, to be honest, at this point was still very unknown. There were a lot of reports out there, and what we were seeing clinically was really all over the place. But we kind of narrowed it down to 3 things. So we thought, okay, what's going on in the lungs, what's going on in the heart, and then what's going on from a clotting standpoint or a thromboembolic standpoint. So from our standpoint, from the lungs, we were kind of worried about a few things. So one, we were worried that having COVID may potentially give you either transient or chronic or permanent, we weren't sure of the time span, actually physical changes in the structure of your lungs that would actually cause air to get trapped. And we were concerned specifically with divers that would put them at risk for barotrauma, like an arterial gas embolism or a pneumothorax or a collapsed lung. We were also worried that we were seeing people, certainly clinically, that we had what we described as a shunting phenomenon. So essentially the blood was not getting oxygenated as it was going through the lungs. And so we were seeing people who had like profoundly low oxygen saturations, which obviously would be dangerous while diving as well. We were worried, again, more about the chronic long-term changes of potentially having pulmonary fibrosis or reactive airway disease. And the reason that we were very concerned about this is, so although COVID was new, coronaviruses are not new. So I'm sure many of you remember the SARS and the MERS epidemics. So where we got a lot of our information is we actually went back and read, basically every pulmonary paper published from those epidemics and really tried to glean and say, okay, structurally, the coronaviruses are all in the same family. We're seeing very similar things with COVID. It's probably reasonable to expect that we might see some of these same long-term complications. The other thing that we were very worried about with COVID was the cardiac involvement. And this actually was very interesting because this seems to be more unique to COVID as opposed to the other coronaviruses. But what we were seeing, and especially in the early days, this was like very widely reported, is that there seemed to be actually direct invasion of the virus into the myocytes, which are the cells in the heart. So we were concerned that they were actually getting direct cardiac invasion and that we were going to have pretty bad cardiac complications. And then lastly, the clotting complications. So pretty early on, we recognized that people were having increased risk of blood clots. So whether that be a deep vein thrombosis like in the leg or a pulmonary embolism in the lung, we knew that we were seeing that. It really wasn't clear to us at the beginning, and I think it's still a little bit unclear how long after your acute illness you're at risk for clotting. And then the other thing is that it's long been hypothesized that decompression sickness actually may also be related to clotting disorders, and that people who have clotting disorders may be at increased risk for decompression sickness. So we were wondering if people who'd had COVID, if they had this kind of hypercoagulable or increased risk of clotting, are they going to be at increased risk for decompression sickness? So when we were trying to figure out, okay, how are we going to evaluate our divers? How are we going to get them back in the water? These were really primarily the three areas that we were focused on. So, like I said, our goal was we wanted a way to get to kind of uniformly screen divers, evaluate them for COVID-19 specific medical conditions, and then hopefully get them back in the water as safely as possible. We needed guidelines that were both sensitive and specific. We joked, we're like, sure, we could be 100% sensitive and no one who has ever had COVID could dive again. That would be easy. Then we wouldn't have any injuries. But obviously, that's not what we wanted. We don't want that for our divers. Also, everyone who works at that clinic is a diver, so we don't want that for ourselves as well. And also, it's not reasonable. But we also wanted to make sure that we were keeping people safe and catching things that were going to be potentially injuring them. Other things that we had to take into consideration is cost. So obviously, we can't break the system ordering tons of expensive tests on everyone. The other issue was testing availability. So again, we, like in our clinic, for example, we had a whole period of time where we had a lot of trouble getting spirometry or pulmonary function testing because of the concern of potentially spreading airborne particles by actually doing the testing. So there was a whole different protocol. You had to go to a different building. You had to get an appointment. It was actually very painful to do. So for people who did not have COVID, we actually waived that for a couple of years. All of the organizations did and said, you don't have to do this as part of your employment physical until we can get more easy access to testing. This wasn't just us. I gave a kind of a similar talk about a year ago in Australia. And one of the doctors there was saying, oh yeah, he's like, I still can't do spirometry in my clinic. So I bought my own machine and I put it outside and I just do it outside with my patients. So we were not the only ones who were having limited access to testing. But it was something that we really took into account because we wanted to make things as easy as possible for both physicians and patients. And then I say novel infection. I mean, that phrase has been used to death at this point, but it really was true at this point. We were working with very little actual knowledge of what COVID was. And so we kind of just had to do our best. And like I said, we really took a look back at our experiences from other respiratory illnesses. Obviously, there's a lot of data on influenza. There's a lot of data on other respiratory illnesses. There's some data on other coronaviruses. So going back through that literature and drawing from those experiences is where we really got the crux of our information. So these were the first guidelines that got published. And I'll go over these in a little bit more detail, but the nuances are not super important. But the idea here is what we decided is that, okay, we can probably look at patients and similar to other respiratory illnesses, our suspicion is that the chances of someone having a long-term side effects and permanent damage is probably going to be related to how severe their initial illness was. So the first thing that we did is that we wanted, when we saw patients, is we really got a detailed history of their initial illness. The thing that I want to bring up now, and I'll say this probably 5 more times throughout the talk, is that these guidelines and all subsequent updates are very specifically only to be used on people who are fully recovered. So for us, that meant that they were completely asymptomatic and that they were back to their normal exercise tolerance. With the caveat being that normal exercise tolerance for them is something that we consider to be satisfactory for diving. So occasionally I'll get a patient who says that they have a normal exercise tolerance, but then when you ask them, they tell me that their exercise is like walking from their couch to their kitchen. So in those cases, we do a little bit more exercise testing, but for the most part, our divers are very fit. And so we would make sure that everyone was asymptomatic. If people were still symptomatic, they just don't fit into these guidelines, and we would just evaluate them on a case-by-case basis. So these are how we broke it down. So category 0 were either people who didn't have COVID or they were completely asymptomatic. So again, this is back in the day when a lot of us, including myself, we had to get tested every single week for work. So occasionally people would have an asymptomatic positive test. We didn't have that many people who were actually asymptomatic. When you would kind of ask people questions, most people actually fell into this kind of category 1, which is like they were having like pretty mild symptoms, but were not truly asymptomatic. But those people were everyone who were able to stay at home as an outpatient. They never had an oxygen requirement. If they did have a chest x-ray, it was normal, or they just never got one because they didn't need one. Category 2 were what we considered moderate illness. So this is anyone who got hospitalized but didn't have to go to the ICU, anyone who had an oxygen requirement. So all of this was a lot of people who just kind of got admitted to the hospital for a few days, maybe were on some couple liters of oxygen, but never ended up having severe complications. Category 3, so this is anyone who went to the ICU for any reason, anyone who had any cardiac involvement, or anyone who had developed a clot, whether it be like a DVT or a pulmonary embolism. Those were all put into our severe category of illness. So based on that original evaluation, we would put people into their category, and then we based our workup on what their initial category was. So for our category 0 people, again, people who are completely asymptomatic, we didn't do anything differently. So if they were here for their yearly physical, we would do whatever the physicals required. And like I said, at that time, the spirometry was getting waived because we didn't even have access to it easily. And they just went about their business. For people who had mild illness, at minimum, everyone got spirometry, which is just the most basic pulmonary function testing, and a 2-view chest x-ray. For those that were a little bit more ill in the moderate category, we would still do the chest x-ray and the spirometry. And anyone who had an abnormal chest x-ray, we would then move on and get a chest CT. We were also doing EKGs and echocardiograms, which is an ultrasound of the heart, essentially to look at the heart function, and then any other kind of complications that they may have had. For those that were with this severe illness, it was essentially the same, but we also added on an exercise echocardiogram with an oxygen saturation probe. So actually having people exercise in a lab with an ultrasound on their heart and also a probe on their finger to make sure that their oxygen saturation did not drop. And so I'll say this again, this was really only to be used on fully recovered asymptomatic divers who are back to their normal exercise tolerance. So anyone who was telling me that I'm still winded, I still have a nagging cough, I still have something else, we would just not use these guidelines. That being said, oftentimes the workup was very similar, but we would just kind of take those people on a case-by-case basis, and they were not meant to be thrown into these guidelines. So like I said, unless you were asymptomatic, the real minimum workup was a good physical exam, a 2-view chest x-ray, and some basic spirometry. What we did not have, interestingly enough, is so a lot of the questions that we got were, what are the mandatory times for people being out of the water? We didn't specify that. Our thought was, as long as you were asymptomatic, we don't have a firm guideline of when we feel like you don't have to necessarily be out for 2 weeks. You don't have to be out for a month. If you feel good, you're back to normal and you're back to exercising. From our standpoint, as long as the testing looks good, you were okay. Practically speaking, with all of the quarantine rules and the way that people could get into our clinic, it was probably at least 10 days to 2 weeks since people got sick before they would even be evaluated and go back into the water. We didn't write about a mechanism for evaluating patients with persistent symptoms. The reason for that is, like, quite frankly, the persistent symptoms that we see from COVID are such a spectrum, is that everyone just needs to be taken on a case-by-case basis. I've seen a lot of patients who still have long-term issues from COVID, and the workups that we've done for them are just really tailored to that individual patient. We also didn't put in a prescriptive exercise test. Partially that is because we don't do exercise testing in our office. And also I know that everyone does different exercise testing. And the idea was that our hope was that these guidelines could really be exported and used by anyone who had a clinic and saw divers, which is good. They actually were. They were adopted by a lot of national organizations and even some international organizations. So we were very happy that they were useful for people, but that's why we didn't specify what the exercise test needed to be. We also didn't define what a satisfactory exercise tolerance was. The reason for that is that in our clinic, we firmly believe that a satisfactory exercise tolerance is kind of relative to what type of diving you are doing. So we have commercial divers who are doing underwater welding, who are extraordinarily fit. They have to be extraordinarily fit to do their jobs. We also have people who are older, who diving is their main form of recreational activity, but they do warm water diving, they do boat diving. It's not something that requires a ton of physical endurance. And so for that case, we kind of follow the recreational dive guidelines put out by Dan, saying that you need to have essentially an exercise equivalent of 6 METs, which is not that high. So that's how we didn't specifically define that in our guidelines. So we published the diet guidelines. So we implemented them locally and published them internally in May of 2020, which was pretty fast turnaround considering that COVID had only been around for about 2 months. And then we published them in a journal in September of 2020. So this is, Ken kind of alluded to this when he was giving the introduction. So after that, we actually started a study at UCSD where we enrolled divers who had had COVID that came through our dive clinic. The reason for that is obviously we published these guidelines with the best of intentions, but we also wanted to make sure that they were working. And we wanted to be able to evaluate ourselves and see if we were missing things, see if we were catching what we thought we were catching. The good news is that we have had mostly patients with mild illness, which I think is the experience that has been worldwide, which thank goodness. We had a lot of abnormal chest x-rays and CT scans. They are generally correlated with the severity of disease. So generally, the sicker you were initially, the more likely you were to have residual findings on your chest x-ray and CT. We've had a fair amount of abnormal spirometry, and it's been interesting. Those are not always as correlated with the severity of the disease. So we've had people who've had come in with abnormal spirometry even after having a fairly mild illness. That being said, a lot of these people will actually normalize over time. So sometimes all we need to do is just wait a few months and repeat it. I'm not sure, honestly, how specific to COVID that is. We're looking for it right now, but we don't always do this after every other respiratory illness. Would you do the same thing would you see the same thing with everyone who had influenza? Perhaps. It's hard to say, the data is just not there, but we've definitely seen it. So obviously the pandemic is here to stay. I stopped updating these slides with total number of cases because honestly, it just got too depressing. But as you can see, COVID is here to stay. The good news, I think, is that we have gotten better at treating COVID. So if you see this slide up here on the top right, so the blue is the total number of COVID cases. This was at our hospital. The orange is the number of people who were intubated on a ventilator. So you can see as even though the blue peaks got a lot bigger with subsequent waves, the orange peaks got a lot smaller. So I think A, we got better at treating COVID. 2, I think this virus has actually evolved into a more mild form, which is very fortunate for us. That's evolution at work because it's also good for the survival of the virus. But you can see here too, this is kind of intensive care versus other hospitalized patients. So even though we had this like massive wave when we had, I think this was our Delta wave, we did not see the same proportion of intensive care hospitalizations. So overall, although COVID is here to stay, it's good news. We also developed vaccines, which have been a huge boon to us. It's really been seeing a lot less total cases, but mostly what we've seen is really decreasing in severity of illness, particularly amongst our elderly and more vulnerable populations. So you can see here, again, these are very hard to read graphs, but the idea here is essentially the fatalities by vaccine status. And obviously the greens are the people who are fully vaccinated. And you can see that their fatalities are just way less than the people who were unvaccinated. So this was a huge thing for our population. And I think that's something that was very protective. So fast forward 2 years, and we felt like it was time to reevaluate our guidelines. And partly this coincided with the fact that we had seen an evolution of the virus. We also had the development of vaccines. And then we saw a huge increase in the Omicron wave. So I think that was around winter of 2022. And all of a sudden, our clinic is just getting flooded with patients because I think everyone got COVID from the Omicron wave in like December, January, February. So we kind of had this huge influx. And what we noticed anecdotally is when we were talking to people, it seemed to be much more mild than the original COVID cases that we had seen. The symptoms also tended to be more upper respiratory. So we started hearing a lot more about sore throat, runny nose, less so about this like deep cough, less shortness of breath. And so we kind of started thinking to ourselves, like, okay, do we need to do spirometry and chest x-ray on every single patient who's had symptomatic COVID? At this point, like we were really still seeing that the data was suggesting that there's evidence of chronic lung disease. And some of it was actually not, some of it was seen with a mild disease. So we were kind of really torn about this. The other thing too is that we really wanted to think about whether or not we should take vaccine status into our new guidelines. Should it matter what your evaluation was if you've been fully vaccinated or not fully vaccinated or partially vaccinated? It got very confusing. It was hotly debated amongst our group. Honestly, what we decided is that it probably doesn't matter. The idea is that if your vaccine is going to protect you from getting more mild illness, then that'll be taken into account when you're in the guidelines. So you'll hopefully just be in a lower category. We also realized that, again, because these guidelines were really being used all over the world, there was no way that you could take into account like every single different vaccine that was available around the world. So ultimately, we did not write vaccine status into our guideline update. We also had the chance at this point to actually look at other people's guidelines. So a lot of guidelines got published about kind of return to play, return to sports. Similar, well, we were, I think, probably one of the first people who published guidelines, but then over the next 2 years, there was like a lot of guidelines. The good news is that they were actually all very similar to ours, which was great. These were some of the cardiac guidelines that people published. There was a bunch of guidelines that were published in athletes. But the good news is that really people were kind of going through the same similar route that we were, which is like, okay, look at their original illness, look at their symptoms. If they're feeling great, like maybe we don't need to pursue this as much as we thought originally. The incidence of myocarditis and the inflammation of the heart muscle that I mentioned earlier, turns out that's probably a lot more rare than we thought and probably just being overreported, which is great. So people kind of calm down a little bit, and instead of suggesting like an echocardiogram and a cardiac MRI for every person or every athlete who had COVID, we really were able to go back and kind of go back to a symptoms-based evaluation, which saved people a lot of workup. And ultimately, I think ended up being very appropriate. So as I said, when we were doing updating our guidelines, so this is in real time, right around Omicron. So none of the available data that we were looking at that suggested heart disease, chronic lung disease, none of that had taken into account the Omicron variant. And I already touched on this. And then we had this thought about like, what do we do about vaccines? So what we decided is, and we published these in February of 2022. So this was kind of right like in the midst of the Omicron wave. We decided that we were going to add a new category. And this is called category 0.5, which we very cleverly named very mild illness as opposed to mild illness. And what we defined this as is this was really for people who did not have lower respiratory symptoms. So this were the people who had isolated upper respiratory, runny nose, congestion, maybe loss of taste or smell, sore throat, and even with the fevers and some body aches, but without significant coughing, without any shortness of breath, without any chest pain. And what we decided is that for those people, if they were feeling great and back to their baseline, then we didn't think they needed additional testing. So for these people, we stopped doing spirometry, we stopped doing chest x-ray. We just evaluated them in our clinic and said, look, you had a mild case, it appears you're back to baseline, you're feeling great, that's fine, get back in the water. So where are we now? Well, I think we're all aware COVID is here to stay. As Ken was just kind of alluding to, we just went through another recent wave. I don't know the numbers off the top of my head, but anecdotally, I can tell you in the emergency department, we were definitely going through a wave. I think it's going to be around forever. It's probably going to become a little bit more seasonal, but it's something that we're going to have to deal with. It's going to be an ongoing issue for our divers. So it's something that we are going to continue to evaluate and potentially revise. The great news is that most of our divers have been able to make a full recovery and return to work and return to diving. So we've been very pleased. We've had very few divers that we've had to permanently keep out of the water. Just below here, this picture, this is actually some of the work that our divers do. So we do the contracts for a lot of our marine mammal trainers that work with the Navy who are actually training dolphins and sea lions. So obviously we want to make sure that the animals are well taken care of. We want to make sure those divers are back to work. And the good news is that the vast majority of them are. There are definitely ongoing challenges. So like I said, most of our divers have been able to return to diving. That being said, there are people that have not been able to return to diving, and there are people that we honestly don't know the answers to. So this is a chest CT, for example, of one of my patients. I don't expect you to be able to read the chest CT, but what we see here is there's some abnormalities in the structure of the lungs. We don't know what that means for a diver. It's not normal. It probably puts you at some increased risk for accidents. We talk about the barotrauma. We talk about exercise tolerance. We spend a lot of attention looking at symptoms. We do a lot of objective testing. So we do a lot of chest CTs. We do a lot of pulmonary function testing. Sometimes we do exercise testing, do all sorts of things. And the truth is that there's a lot of individual conversations about risk benefit. Some people have chosen to return to dive. Other people have not. Some people have objectively severe disease where we have said absolutely not. Luckily, those cases are rare. The other question that I get all the time is this permanent? And the truth is we don't know. We don't know how these changes are going to evolve. I can tell you that when we were looking at the MERS and the SARS data, particularly with MERS, the incidence of pulmonary fibrosis was somewhere around like 40%. It was extraordinarily high. But you really didn't see like stability and where people were going to kind of end up clinically until about 2 years out from their illness. So we're very much still in this window where I don't think we really understand what the long-term effects of COVID are going to be, especially on the lungs. And some of these things might get better. Some of these things might not. And I don't think that most of the time I don't have an answer for that. Are we seeing an increase in DCS and arterial gas embolism or fatalities? It's interesting. During the first year of COVID, 2020, we saw like no divers in the chamber that were there for emergencies. And I think partially that was just because like people weren't really diving. The year after was the busiest year we've ever had at our chamber for emergencies. So we saw more divers with decompression sickness and arterial gas embolism that we can recall. Is this related to COVID? Is this related to the fact that people were out of the water for a year and like kind of forgot what they were doing? I don't really know. This picture here, so this is someone who has cutis marmorata. You can see here, this is a picture of like the marbling on the flank. Interestingly enough, this person had pretty bad case of decompression sickness and was actually found to be positive for COVID, even though they had said that they were asymptomatic. Did that put them at increased risk, maybe doing to be a little bit hypercoagulable or more prone to forming clots? Don't know. That study is going to be very hard to do because there's just like not enough people, but it is something to pay attention to. I can tell you that Divers Alert Network, the year like 2021, also had like one of their highest years in fatalities as well. But again, it's really hard to point to what that is. Other ongoing challenges that we're dealing with. So long COVID is a big one. We see a lot of patients with long COVID. I think this is, particularly sad because we see this in a lot of young people who actually had fairly mild initial illnesses with COVID, and then some of them, for whatever reason, seem to go on to develop this syndrome that we, colloquially call long COVID. There's a lot of variation in symptoms. We see a lot of people with chronic shortness of breath, chronic fatigue, a lot of this kind of sense of brain fog, postural orthostatic tachycardia syndrome, otherwise known as POTS, which essentially results in like extreme lightheadedness and high heart rate, especially with changing positions. It's really not clear what exactly causes this. There's a lot of speculation. Some people think actually it may be due to ongoing like microclots forming in your circulation. There is a speculation that actually treating with hyperbaric oxygen may help these patients. We've treated a few in our chamber. There's been anecdotally some like very positive responses. I can tell you that there's been some people who've had less positive responses as well. So I don't know where that's going to go, but it's interesting. And I think it's going to be something that we are going to be dealing with for a long time. Other things is that we're seeing increased risks of comorbidities that put people at risk for heart disease and other complications, especially in divers. So the other interest that I have in my research is actually, I've done a lot of research on diving fatalities. And one of my personal pet interests is really understanding the risks of heart disease and diving. It's probably very underrecognized and a very underrecognized cause of diving fatalities. And what we're seeing is increased risks of diseases that put you at risk for that. So, although this affects everyone, I get particularly concerned about this when I think about my divers and think about things that are going to put them at risk for a diving incident. We're definitely seeing increased risks of type 2 diabetes. We've seen increased risks of cardiovascular events and stroke. And again, I don't know how much of this is directly related to COVID. Is it related to a more sedentary lifestyle and decrease in other kind of healthy lifestyle activities that happened during the pandemic? Probably is a combination of all of those things. And we're still seeing, significant rates of ongoing pulmonary disease, at least a year post-recovery. I was just reading a study today, actually, that was one of the better studies that came out because a lot of people were not looking at outpatients. They were only looking at inpatients, but this one included both. And even in those patients that had mild disease, there was somewhere in the nature of 10 to 12% of people who had residual pulmonary disease at a year. So it's real. I think this is going to be something that's going to be an ongoing issue for us. I feel like every day we discover something new that's associated with COVID. Some of it I think is a little bit of folklore. Some of it is probably real. Hard to say. My coworker's son had COVID 2 weeks ago, and then the week after got appendicitis. And she was talking to the surgeon, and he's like, oh, yeah. He's like, we see this all the time in these young people. They get COVID, and then bam, they get appendicitis. And we think it's because their appendix gets inflamed in this post-inflammatory state in COVID. I don't know if that's true. I have not seen that study, but it's interesting. And you're probably going to hear, again, all sorts of anecdotal stories. But there's stuff going on, and it's going to be here to stay and things that we're going to be dealing with for the time being in the foreseeable future. So I'm going to stop here, and I just kind of want to emphasize a few take-home points. So I do want to say, COVID-19, although luckily most people have been recovered very well, there are specific things about COVID that will put you at increased risk for diving. And those are really related to the pulmonary complications and the cardiac complications as well. We really still recommend that any diver who wants to go back to diving after having COVID be evaluated by a physician at a minimum, especially if there are any residual symptoms. And I really can't emphasize this enough. We've had cases where people who have had relatively minor residual symptoms, we have found significant findings that really would prohibit them from diving safely. We've also seen diving accidents happen to people who in retrospect had some residual symptoms that they had not told anyone about and probably caused their diving accident. So I really just kind of emphasize that to everyone, and making sure that people are returned to their baseline exercise tolerance. Because even that mild shortness of breath with exertion that's new, that's a sign that something could be going on. And anyone who had a really moderate to severe initial illness. And then again, the guidelines that I reference here, just to remember that these are really to be used only on asymptomatic, fully recovered divers, and that anyone who's having residual symptoms just needs to have an individualized evaluation by their physician. And with that, I will take any questions. This is our other chamber that we have down at Hillcrest. This is our emergency chamber. So if anyone's ever down at San Diego and needs an emergency visit to the chamber, this is my lovely team, and this is where you're going to end up. We love this chamber. She's been around for a very long time and has treated a lot of divers. So with that, I will stop sharing and open it up to questions.
And there we go with the stop share. Well, we always start with the first Zoom seekers. Thank you. That way everybody doesn't have to open their microphone, and we don't have cats and stuff going in the background and everything else. And just to let you know, Charlotte, we actually do have a couple of doctors on the Zoom seekers thing with us tonight, as well as a couple of chamber people as well. So they may have some different questions. I always get to start with the first question, and for you guys, you can either do the actual raise your hand or use the little icon, whichever works. But I've had COVID twice, and one thing I've noticed is I still think I have a slight loss of sense of smell, not a loss of sense of taste, although some of you say I have no taste to begin with. But anyhow, but a little loss of taste. But I also know, because as I've mentioned to Charlotte, most of you guys know, I'm also an actor. I feel, because I do voiceover work, my throat, when I speak, it's more gravelly than it used to be. It's just not quite as clear. I'm associating that as a COVID thing. I don't know, but I mean, anything that you've seen, and that might be something that you don't really look for because, not like divers are talking underwater.
Yeah, I mean, I'll say like I've heard almost everything reported and I believe it. I think that I haven't seen any like specific literature with that subject, but to be honest, like that's not something like you mentioned, that I look specifically for, because it's not usually something that my divers bring to me. But yeah, I mean, like we just heard essentially anything on the spectrum that people can report, we've heard it reported. And it's probably real. I think this is a virus that's been very interesting. It's mutated a lot. So the version of the virus that you've had may be different than what someone else had. But yeah, the residual symptoms I think are real and just like all over the place.
All right. Who's going to be next? Someone's got, there we go. I know I can always count on Andrea. Andrea, you got, and Wendy.
This question may sort of fly in the face of something you said, but right now, for those of us who dive at aquariums and museums, etc., the guidelines, if we've had COVID, even a mild case, dictates getting another dive physical. We don't do that with flu. Are we ever going to reach a point where, very mild COVID and influenza are treated comparably, or RSV? Yeah. Because it seems like we have a fairly big reaction to COVID, less so for other kind of respiratory illnesses.
That's such a great question. I think hopefully we will get there, because I agree with you. We don't do this for every other respiratory illness. And I kind of alluded to this too, is, some of the findings that we see with COVID, especially with like the more transient spirometry changes, I suspect if I did that with everyone who'd had influenza immediately afterwards, I probably would see that. I think honestly right now, why we haven't gone there is there's also been a huge tendency of people to minimize symptoms. And to want to get back to work and like not necessarily being truthful. So I think that's why people have been a little bit more on the cautious side, and it's still kind of trying to mandate an examination. But I agree with you. I think at some point, realistically, we're going to get to the point where like, hopefully we can get the public understanding of like, this is just to keep you safe. If you have residual symptoms, if you had more than a very mild case and you need to be seen, but I'm hopeful that we'll get there too, because I think it's here to stay, as you said. And I think that you're right. We don't do that after every other respiratory illness. And I also think that we're going to get more data on what happens to people who've had very mild illness. It's still fairly new in the world of like medical research, where it takes like a year or two to get stuff out. So hopefully we're going to get more data on that soon, and then potentially kind of hopefully revise the guidelines there.
And Andrea, I'll add. So Andrea dives at the California Science Center. I'm a diver, as well as one or two other people on the call, at the Aquarium of the Pacific in Long Beach. We just updated our COVID protocols to make it that if your primary care physician wants to sign just a return to work authorization, that's acceptable rather than, the full physical, which was our standard for a while as well. So Andrea, you could let Andrew know that that's what Paul says is okay. Maybe he'll follow suit.
And I don't know if Bromley wants to comment on this. He's sort of been through the mill lately.
Bromley, you want to unmute and chime in?
Yeah, I'll jump in. So I actually went through my re-exam yesterday, and that's when I heard about the 0.5 rating on COVID. So that seems to have sort of migrated a bit, but I got a sense from the physician it's still very much uncharted territory and people are finding their way.
Yeah, I mean, I think that's true. I think, like I said, we still hear cases all the time. I heard about a case last week that, this woman she had like a very mild residual cough after COVID and didn't go see someone. And she ended up with like a catastrophic diving accident with a collapsed lung. It was a whole situation. And she'd had a very mild illness and just had a very slight residual cough. And so, I think that's why, like, yes, it's an N of one, but we get these stories and we're like, well, this is why we're still being cautious. I think we still don't totally understand. I mean, the rates of which we saw things like collapsed lungs and blood clots and things like that, it is definitely different than any respiratory virus we've ever seen. It is unique. And I think we still don't have a complete understanding of it.
Charlotte, would we also have a problem, as you sort of said, we're a tiny little sample group. So as I always like to say, I'm fascinated by statistics, but I'm not a statistician. But the short version of that is, as you reduce your sample size, you're going to increase the odds that, what you're looking at really is not representative. So does that factor into all of this as well?
Yeah. And I think that's why, when we look at our guidelines, we're not looking at studies on divers. There just aren't any. We actually just stopped enrolling patients in our study like 2 months ago because we got to a point where we wanted to stop. We were at about 110. So we're hopefully going to publish our results the next few months, which, but again, like there's not really much out there on divers. So yeah, we're trying to take, when we look at these guidelines and like long-term implications, we're trying to pull from the general population, because if you went just to look at divers, yeah, you wouldn't have anything that was like statistically meaningful.
Who else has a question? And actually, I'll put Carl on the spot because we have Carl Huggins on here, who's the director of the Catalina Hyperbaric Chamber.
Yes. Hi, Carl. Good to see you.
And Carl, are you seeing? I guess when someone comes in, you're not going, "Oh, was this caused by COVID?" Whereas if they hadn't had COVID a year ago, this wouldn't be an issue. But has the COVID stuff affected the way you treat people as opposed to protective measures you might take with the staff?
So I was just on my way to unmute.
Carl, we can barely hear you.
I was just on my way to unmute. So let me change over here. So
Hang on. He's switching over from the Dragonfly.
Okay, is that better?
Night and day. It's
Okay.
almost like the previous one was COVID infected, and this one is now you're asymptomatic. Fire
Right.
away.
So, like I said, I was about ready to unmute when you brought my name up. But anyhow, I was going to sort of run by the concept of, you said that you've seen a lot more cases than you normally do in the last few years, whereas we have seen quite a bit fewer cases out here brought into us. And so I don't know if that's just are you seeing most of your cases from just offshore, or are you seeing them from dive boats, or a combination of the two?
Most of ours are dive boats or shore diving, just off La Jolla. Yeah, I don't know if that's necessarily related to COVID. I almost think a lot of it is more related to people like having been out of the water for a while during the pandemic, and then like maybe just kind of forgetting some basic skills, and just not being as, there's just a lot of like training that goes into it as well. So that's kind of been my suspicion. So yeah, I don't know if that's truly related to like a COVID thing or more of a pandemic isolation, not being out diving regularly thing.
Yeah, and I look at it from the perspective, we've seen a large drop in the number of dive boats. The dive boats who are running now, I don't think they've increased their numbers back up to their within the COVID pandemic numbers that they used to be running. So I think the numbers coming out are just primarily focused on the underwater park at this point in time.
I mean, and I would tell you, even the underwater park, obviously we don't track numbers of divers or numbers of dives, and so we know numerators but not denominators. But even going out to the underwater park, comparing a weekend out there now and a weekend pre-pandemic, night and day. I mean, I'd say 50%.
Wow.
Which obviously then will affect the number of cases you might see.
Yeah.
And go ahead.
I was just gonna say we've had a pretty good recovery, I would say, of like diving in San Diego. There's still, I don't know our numbers are completely recovered, but we've had definitely, but that first like 2020, yeah, we had almost no cases, and it was just like the beaches were just very empty. Same thing with our dive boats. They were running at like very limited capacity, but I think they're back up and running at full capacity.
And then in terms of what we do, generally we make the assumption that anybody coming in should be considered potentially infectious. And so our tenders inside wear masks. If it's something that requires, a lot of intensive care, somebody who is unconscious, somebody who's in respiratory arrest, cardiac arrest, then we pile on the protective equipment for them. And I know during the height of the pandemic, what we were doing was on our what's called BIBS, a built-in breathing system. And during the treatment, you have the patient breathe oxygen and then breathe air. Instead of taking them off the mask, we just switched the gas supply on the outside. So we kept them on the mask, and all their exhaust was being dumped outside as opposed to into the chamber.
Yeah, that's what we did too. And yeah, we were lucky. I think we have a very busy multi-place chamber, and we're running 3 treatments a day. And we were very lucky. We actually had like no transmissions of COVID in between any of our patients or staff, which we felt very, very grateful for. And we were able to remain open during the whole pandemic and treat all of our patients. But yeah, it took some creativity, I would say.
Yeah.
Susan Bangaster, I see you've unmuted. I'm assuming that may mean you have a question.
Yeah,
And Stacy will get to you next.
Oh, well, I had a question. I don't know if your study included observation of patients who might have had Paxlovid. I assume Paxlovid then would reduce the symptoms, make them milder, so maybe they're less likely to have complications. But I don't know if you noted anything about Paxlovid use.
That's a good question. We did not include that as part of our study. Yeah, it's kind of the same thing as the vaccines. We kind of just use severity as a surrogate marker. But it is interesting. Yeah, hopefully we would see less severity in those who had Paxlovid, but we didn't specifically include that in our study.
Thank you.
Stacy, you are up.
Hi, thank you. I'm not a science person by any long stretch of the imagination, but I do travel quite a bit internationally and have contracted COVID, I believe, twice. I mean, once for sure on a trip to Egypt, the first time I got it, and then the second time with reef seekers.
That's right. 9 out of 18.
Like
you get COVID at no extra charge.
Right. And even though, I didn't officially test positive, I'm pretty sure I had it. And so I'm wondering, like, are there any statistics or thoughts around increased risk of international travel, long flights, traveling to really, kind of funky places, like Indonesia and Egypt, and I'm going back to Indonesia, and just, do you have any words for the wise, or are there any statistics concerning like increased risk due to, flights and that nature of travel?
Yeah, I mean, I think for sure travel is something that we always think about as a risk. From my reading and understanding that planes themselves are probably less of a risk than we originally thought, because they're actually circulating the air pretty well in there. That being said, I still wear an N95 every time I travel, all flight, all airport. I wear one every shift, all ER. So I am like a fervent masker. And I make my husband do it too. We just got back from Italy, and he was like not pleased about having a N95 for 12 hours on a flight, but he didn't get COVID. I think, where we actually see is when they look at like the studies of like the airports and stuff, where you actually see the biggest risk is like in the terminals, in these like crowded hallways where people are like walking through, they're unmasked, they're eating, they're drinking, and you don't have the good air circulation. So that's kind of like me personally, like that's where I double down, and like I won't take my mask off in an airport. Like I'll take it off on the plane to eat, but like that's just like my personal experience. But yeah, travel is rough. I'm with you. I love to travel. And it's just one of the things that like, it's a risk still, and being in crowded places with lots of people. I don't know. It's kind of like a risk benefit thing, but yeah, I think the plane stuff is probably what came out of that is like probably the air circulation on the planes is a little bit safer than we originally thought. And airports are probably a little bit more dangerous than we originally thought.
Right on. Thank you very much.
I mean, the ironic thing with what Stacy mentioned is I had gotten a year ago the updated vaccine 3 weeks before our trip, specifically so I wouldn't get COVID there. And this was also a time when there was a new strain coming out of Asia. I don't know if our vaccine was engineered for it or not. So I think the other, non-layman answer, Stacy, again, I'm not a doctor, but I played one on TV. The non-answer is, you do the best you can, but I don't know that, what we get here covers every strain all around the world or vice versa. So you just don't know. And unfortunately, it's a pass-fail test, and you don't know you failed until after you get the result back. Any other questions? I'm looking around I can see the whole group on this other computer.
I will make one comment in part.
Sure.
For those who are in LA, tomorrow is going to be a way cool day where the solid rocket boosters for the shuttle are being delivered to the Science Center, and you'll be able to welcome those tomorrow morning. It's pretty exciting stuff.
And do those solid rocket boosters have COVID, or have they been vaccinated? Do you know?
No, but they've been wearing their masks.
Well, but they spew a lot of stuff. So,
Very
I guess what's the timing on that, Andrew? Do you know offhand?
There was an article about it in the LA Times today. I think the official arrival time is like 8:00.
I was saying it was early. Yeah.
Where they will, bring it into
I
Expo
think they're
Park.
bringing it down overnight from.
Yeah, it's being driven down
Mojave.
to, it was stopped last night somewhere along the 605. And so it will be transporting tonight with the idea that there will be sort of a welcoming ceremony tomorrow morning.
Very cool.
And then you can watch Andrea dive in the tank after you watch the.
And
welcoming.
Wendy, they're exhibits. They're not tanks.
It's a tank. It's a giant fish tank.
None of us are allowed to call them tanks. They're exhibits.
Okay. The
But very good.
kelp exhibit.
Very good. Very cool. So if you're down in Exposition Park area tomorrow, have at it. You'll be outside, so maybe you won't need a mask. But if Charlotte's there, she'll be probably wearing her mask anyhow. I did think, Charlotte, by the way, it was interesting when you mentioned the whole spirometry stuff and that you weren't, doing that for a while at the clinic. When I got my last physical for the aquarium, because I have to get a physical every year for the aquarium, and it was about 9 months ago. And we are still doing spirometry, but they literally walk you outside, and you do it outside, right next to the street where all the cars are fuming. Who knows how that affects it? But then they have, and I didn't even think about it in terms of, are you spreading exhaust fumes as it were if you were inside? But now it makes sense as to why they walk you outside to do that.
Yeah.
Yeah, fun stuff. All righty, everybody. Well, once again, let us give a Zoom Seekers thank you, please, to Dr. Charlotte Sadler for sharing all of her insight with us and all that good stuff. And, the best advice we can give you probably is do the best you can with what makes you comfortable. I don't wear a mask as much as I used to, but I usually still carry one in my pocket just in case I feel uncomfortable, including last night at Dodger Stadium, although I think I rather would have covered my eyes instead of my mouth, but that's the way it goes. What are you going to do? Our next Zoom Seekers is November, wait a minute, I forgot the date, November 14th. And that is going to be Stephen Wirtz. Stephen is the regional director. I don't know if it's his exact title, but he's works for California Department of Fish and Wildlife, and he's in charge of all the marine protected areas that are in our region. And we just went through what we call the decadal review. Those have been in place for 10 years now, the MPAs. And so part of the process is that every 10 years you do a review and decide what's working, what's not working, what do we need to change, blah, blah, blah. And so he will be talking about that. So make a note to join us on November 14th for that, if you can, second Tuesday of the month, as always. So again, Charlotte, thank you so very much for
So much for having me.
spending time with us. that was terrific, good information. And hopefully, you guys can put all this into good practice. And COVID's mild now, but it's one of those things I still think you'd rather not get it than get it and say, it wasn't that bad, because you never know. So anyhow, thank you all very much for spending some time with us tonight with Zoom Seekers. We will see you in November for another edition of Zoom Seekers from Reef Seekers.